Well, good afternoon, and thank you for joining us today for the February meeting of the Indiana Commission to Combat Drug Abuse. I'm Doug Hunsinger, the Executive Director for Drug Prevention, Treatment, and Enforcement, and Chairman of the Commission. We have a full agenda this afternoon, so let's check off our first order of business. Seeing that we have a quorum and the minutes were distributed to the members in advance, may I have a motion to approve the minutes?
This is Devin. I'll make that motion.
Thanks, Devin. A second.
This is Jacob Sipe. I'll second.
Thanks, Jake. All in favor?
Aye.
Aye.
Perfect. Thank you. The minutes have been approved, or the minutes from the November meeting have been approved. As is routine, I'd like to kick off each meeting with an update on the state's effort in our fight against the drug epidemic. And I reported in November that we had seen a 33% increase in fatal overdoses in 2020 over the previous year. And 2 weeks later, following that meeting, the CDC reported nationwide drug overdose deaths topped 100,000 deaths in a 12-month period for the first time ever. This is a stark fact attributed to COVID-19 and the rise in fentanyl use. This number has made our work more important. Since the start of the pandemic, our state agencies and external partners have worked tirelessly to make life-saving interventions accessible to all 6.7 million Hoosiers, and that work continues today. On December 7th, we announced at the St. Joseph County Jail the first of 19 naloxone vending machines in the state, and this was made possible through a partnership with the Division of Mental Health and Addiction and our partners at Overdose Lifeline. Since then, 4 more machines have been placed at jails, hospitals, and community correction centers in Wayne, Du Bois, Tippecanoe, and Clark counties, with more on the way later this month. These machines hold up to 300 doses of free naloxone and provide zero barrier access to the medication. We recognize that so much of the care and so much of the work to prevent substance abuse at its core is best accomplished at the local level. And so to support our locals, the Division of Mental Health and Addiction has introduced 2 new grant opportunities this year. First, the Community Catalyst Grant aims to promote innovative, collaborative, and sustainable local and community-driven responses to mental health and substance use disorder and access to the relevant infrastructure. Applications for this grant are due on March 1st. And secondly, the Community Coordination Grant announced earlier this week, supported by funding from the Governor's Next Level Recovery Initiative, provides the opportunity for communities to support development and capacity building of community coordination focused on substance abuse, treatment, and recovery. And simply put, these dollars are targeted toward funding personnel to manage and organize initiatives related to access to treatment for substance use disorder and mental health. Projects within the justice system linking individuals with justice involvement to care are included in this grant. And this grant can also be used towards community needs assessments and an action plan and the development and support of local coalitions, our local JRACs, and other collaborations. These funds are available to nonprofits who have been in existence for a minimum of 4 years, city, county agencies, courts, and criminal justice agencies as well. Applications for the grant are due on February 11th, so not much time left to respond. And more information on the grants is available on the DMHA website under the Funding Information tab. Next, I'd like to introduce our guest speaker, Sean Odom. Sean is celebrating 4.5 years in recovery after a 17-year-long battle with substance use disorder. Sean's a realtor with the Morris Property Group here in Central Indiana. He also serves as a peer recovery coach at Community Howard Behavioral Health in Kokomo. So we've asked Sean to join us to share the steps he's taken to get where he is today. So Sean?
All right, I appreciate it. Seems like my screen's lagging a little bit. Can you guys hear me okay?
Yeah, we can hear you well.
All right. Well, I mean, my addiction is no different than anybody else's. I mean, it starts off like a Charles Dickens novel, right? It was the best of times. It was the worst of times. What I want to do is kind of start where I'm at today and then go in reverse. So, I mean, today I'm a certified peer recovery coach who loves to remain teachable. Today I'm a father of twin boys who have a story of their own. Today I'm a husband, a son, a brother, all kinds of siblings. I'm a third degree within my Blue Lodge, a master mason. I'm a Shriner. I'm a real estate agent starting my third year in real estate. The coincidence here, though, is that every time I lose somebody close to me in recovery in my 4.5+ years, I get the opportunity to speak. With that being said, this is my 40th speaking engagement. A little over a month ago, I lost the 40th person close to me. But my sponsor always tells me, regardless of what kind of day I'm having, I have 40 friends who wish they were here on earth to have that same kind of day. In March, I decided to get out of the treatment field, working with Landmark Recovery and Praxis by Landmark. And I came over to Turning Point to work with Jamie Whitaker. He had wanted me to work there for a long time because my wife was the very first peer coach that they hired. And I had just gotten leased out to Community Howard November from Turning Point because of the SAMHSA AOT grant. And it's a beautiful thing to be a peer coach and to work with people who also struggle with SMI. You know, in 2020 to 21, I saw the growth in MAT working in the treatment field. And I watched it help a lot more people than it hurt. Now, the previous year, I was gearing up for my wife to have our twin boys because we were given an ultimatum by an IU doctor that because one of the twin boys was not doing so well, we had the opportunity to stay at Community North, and she would be surveillanced, I guess, every 5 seconds, 1 minute, or we could go to Cincinnati and terminate the other twin's life who wasn't doing so well. That was one of the hardest decisions I had to make in recovery. But 2019 was it was a tough year for me, right? That was the year that I was studying my real estate state exam and studying to become a Freemason, my first degree, all at the same time. And it took me 6 times to pass the real estate state exam. But that's because recovery teaches me to not give up. It teaches me to keep pushing through. And regardless of what the outcome is, acceptance is the answer to all my problems today. In 2018, after being at Progress House for about a year, I was hired on as the first paid front desk office coordinator. Daryl Mitchell took me under his wing. My time working at Progress House, I got to see Recovery Works come into fruition. And I got to see an influx of people coming to Silver Living who may have not had the chance to previously. As a recommendation, I became familiar with the Indiana Association of Recovery Residences. Today, I'm looking at joining the board of directors for INAR. But in 2017, I realized that I was living in this triangle, right? I went through 17 years of addiction. I slept behind a gas station for the year of 2015, thinking I had life all figured out. Who would have known 6 years after being homeless, I'd be a real estate agent, right? Because that's the way my higher power is able to work through me to show that we can prevail, right? And if I try this hard today, just think if I would have tried that hard back then. But what I've come to realize is there's no such thing as unresourceful people. There's only unresourceful states. What I lacked when I was homeless, what I lacked when I was in addiction was resources, because I didn't know of the resources. So you take a 17-year addicted, 3-time felon, and you place him for his final incarceration, you place him in CCA downtown in Indy. And he can look down at the Salvation Army Adult Rehabilitation Center where he first attempted recovery. And he chose to go back. And I kept coming back. I came back to jail 2 more times. And after this time, when I looked down there, I knew that right up the street was Progress House, because I'd went to meetings there while I was at the ARC. And back then, I thought I was going to pick up chicks because I had what they wanted, right? No job, no house, no nothing. So I realized from CCA here, I could look out the window and see the ARC. Right up the street, I could see Progress House. The moment that I walked into Progress House, I saw that same symbol, only with a circle around it. And it was the symbol for Alcoholics Anonymous. I had been living in this triangle. I had been living in a similar triangle. But what I lacked was unity, service, and recovery. What I'd lacked for 17 years was resources. But you guys come to work every day and you go, how am I going to make a difference? That's the same thing that I get to do today is come to work and go, how am I going to make a difference? And sometimes the only difference I may make is within me. But you guys get to come to work. You guys get to build these programs to allow people like me. Back then I was a wretch, and now look where I'm at. I have so much gratitude to the state of Indiana. I even have gratitude for the ankle bracelet that they placed me on from leaving CCA to going to Progress House, because that at the time was my accountability partner. When I walked in there, I had 0 clothes to my name. That taught me humility, because I was humiliated. I learned that I was powerless over alcohol and drugs, and that's what got me to the front door. But when I walked through that threshold, I had to change my thoughts. I had to change my behavior. I had to change my reactions to life and start to learn to respond. I really appreciate the work that you guys do day in and day out. Really do, from the bottom of my heart. Because of the programs that you guys have built, I am here today. Because of the programs that you guys built, I am now a member of society who contributes. Because of the programs you guys have built, I'm a father, I'm a son, I'm a Freemason, I'm a Shriner. I'm everything and so much more. Because I was given a chance by people like you. I thoroughly appreciate it. My name is Sean Odom. Thank you for giving me your time.
Well, thank you, Sean, and thank you for sharing. We start out our commission meetings with a recovery speaker for this purpose, to remind us that our work is having an impact. And so thank you for sharing. Next, I want to introduce Dr. Deanna Dwenger and Angela West with the Department of Corrections Behavioral Health Division. They're going to share the recent transformation of the department's addiction treatment programs. Prior to the start of COVID-19, the Department of Correction had started the process of revamping the way treatment is delivered to individuals with mental health and substance use disorders in their facilities. And over the last 2 years, Dr. Dwenger and her behavioral health team have moved from a one-size-fits-all treatment program, from where everyone processes through the same steps, to a level of care treatment model where treatment is now based on the clinical needs of the patient. They've identified the gaps, reshaped the comprehensive framework, and in less than 6 months into the Recovery While Incarcerated program, they've cut their treatment wait list in half, all while providing the quality care individuals need when they need it. And so I couldn't be happier with their progress. And this afternoon, they're going to share how this transformation came to fruition and what's left to be done as we look to provide the best care for some of our most vulnerable Hoosiers. We'll also hear from Damian Guy, who completed the Recovery While Incarcerated program and was recently released from DOC. So Dr. Dwenger, Ms. West, the floor is yours.
All right, can everybody hear me? Okay, I almost want to stop there. Thank you, Doug, for the wonderful welcome. My name is Deanna Dwenger. I'm the Executive Director of Behavioral Health for the department. I'm a psychologist by training. I've actually been doing patient care in the department since 2013, and then I joined the exec team for the department in January of 2021. And then I had the pleasure of hiring Miss Angela West, who is my Director of Addiction Recovery, here with me today. And she has been with me since July of 2021. So over the last year, we've definitely taken a look at the program and tried to find some areas where we could strengthen the program. But we also have a speaker with us today. Damian, are you able to unmute, hopefully? Oh, it still says you're muted.
Let's try it again.
Great.
Have I done it?
You've done it.
Okay. First.
So we're going to start with Mr. Damian Guy, and he's going to give us a little bit about his history and his experience with the Recovery While Incarcerated program, is what it is called, in the DOC.
All right. Well, first, I would like to apologize. I'm not the most computer literate person, so I apologize for the problems I've had coming to the Zoom in the first place. But the things that I've learned in RWI were, I believe, things that I should have picked up in life in the first place. My mindset and the way that I thought ended me up in prison in the first place. But the RWI program, the thing about it is this: the 12 steps, there are 12 principles. And I believe when anyone in any walk of life, when you go by principles in your life and you don't deviate from them, you'll be successful, or the principle will manifest itself in some way, shape, or form, be it good or bad. So that's what I liked about the program, because the 12 steps, if you practice them, they will ultimately change your character and everything else. Because most principles is a principle that we don't deviate from. We believe it as a truth. So we practice it, and we don't change it just because of our mood or to change anytime we're in a different situation. We stand on it at all times, and it becomes a habit. We do it so many times, it becomes habitual. So that's the main thing about the 12 steps. You practice them enough times, they become habitual, and it changes your character. That's just how I see it. I believe that's what happened to me, so I don't know.
Would you say, Damian, that there's anything that made specific to you that made the program work for you, or what makes people successful in the Recovery While Incarcerated program?
I think what made me successful is that I chose to practice. I had two favorite ones. I wrote them down. There were, it was the 12 steps. It was number 3 and number 12, because they had to do with your decision to turn your life over to the will, either to God, however you see it, or to the will of the program's principles. I think that's the key. I had a tendency to just do what I wanted to do. That's not a principled, purposeful life. If you want to get yourself out of addiction, you have to do what the principle says. You have to turn your will over to it, and you have to strenuously do it. It's not easy. It sounds simple, but it's not easy. You have to do it until it becomes a habit. So that was the favorite part to me. After I learned how to do it and I practiced it so many times, it just became habitual. And after a while, I didn't even crave drugs. So it was truly a transformation. That's how I knew if you do this process and you practice it, it works. It will happen.
Thanks, Damien, for telling us a little bit about your story. Angela, are you able to share the PowerPoint?
Sure can.
We've got just a couple of slides to keep me on track, because otherwise, who knows what would happen.
Yeah, especially with me.
Thanks, Angela. So this is who we are. And you want to go to the next slide? Thank you. Okay, so a year ago, when I came into this position, we had over a 3,000 person wait list. And so I was asked to just look at the effectiveness and the efficiency of what we were doing. At the time, I kind of worked with my supervisors to identify where we wanted to go from what the program had changed in 2018. For me, the most important thing was really moving from a time cut program to a treatment model. So instead of having a reward-based, you can earn a time cut and it's a privilege to get into this program, really looking at it the same way that we do mental health, and that it is treatment for the patients that we serve. I wanted to keep the idea of recovery while incarcerated. It's all about providing the right amount of care to the right individual at the right time. That was a core from the rewrite in 2018, and we wanted to make sure not to lose that. We also didn't want to lose the core therapy that was being provided in recovery while incarcerated, as it did seem that the patients and participants in the program were really benefiting from it. By looking at these two things, though, we were hoping to pay attention to the wait time and how we could get people into the program in a more efficient way. And so the next slide I'll go into a little bit more detail about how we did those things. So to get it from program to treatment, it's been a year of trying to do that. And a lot of that came from just having the conversations. We've presented to leadership, the wardens, we've presented to exec staff, we've presented to pretty much anyone who will listen to us speak. So just getting comfortable with talking about it as treatment was the first kind of long process. There was something we did at the beginning of treatment called the Pre-Eligibility review. And what that essentially did is said, are you capable of getting into treatment? Have you had conduct recently? Are you affiliated with a gang? And are you getting yourself into trouble? Where do you live? We kind of wanted to pick the best of the best to get into treatment. And so we were weeding people out of treatment based on some of these other things that could be related to their problematic substance use. So the first thing we did is we removed the pre-eligibility review. Now every person who is referred for treatment will have a comprehensive assessment, and they will be discussed as a multidisciplinary team and decide from there what their treatment can look like. Similarly, we got rid of the gang SS. That was a pre-screener that we had that identified 0 to 5, whether they were eligible for treatment or not. What we found, though, was that it was weeding people out of treatment, not into treatment. So we got rid of that and instead worked with case management to identify patients that could use or that had problematic substance use and would benefit from treatment. That was looking at things like their criminal history, positive urine screens, maybe their interactions with others. They're just kind of looking at them holistically and deciding rather than giving them a number based on this GAIN SS. Urinary drug screens were historically provided by the DOC, and they were used for punitive reasons. So if you got a conduct report for having a positive drug screen, that was held against you. We are now having Centurion, which is our medical vendor, provide all of those urine drug screens, and those results are now used for treatment purposes to identify who's in need. Maybe we need to look at their level of care and to assess them individually. With that, we looked at conduct report utilization across the board. It used to be that you couldn't have a conduct report, like I said, within the last 6 months to get into this program that came with a time cut. And used to, if you were identified as having problematic substance use and you refused treatment, you would get a conduct report. So we just took a closer look at this conduct report and how it was getting in the way of providing patient care. So no longer are they going to get a conduct report for refusing treatment, because what that meant was they would be idle no pay. So we would say, you're not ready for treatment, but we're going to punish you by giving you 6 months of you can't have another job and you can't go into another program, which is problematic because they're already not motivated. And now we aren't helping them get motivated. So now in that time, they can refuse treatment. They can start another program or education and still get a job. And Addiction Recovery Services will work with them during that time period to help hopefully motivate them to join the program. Similarly, if they get a conduct report while they're in treatment, it doesn't mean that they automatically are kicked out of treatment anymore. That used to be the case. But the way that we would not write a conduct report for someone who is psychotic, who kicked a trash can, and say, you're no longer eligible for mental health treatment. That's kind of what we were doing with substance use treatment. And so no longer is that an automatic removal. We will talk about that in a treatment team and review every conduct report. We also have 2 sites in Indiana that are run by a subcontract GEO, that's Heritage Trail and Newcastle Correctional Facility. And in their contract, they provide the addiction recovery services rather than our Centurion medical contract. And a lot of times they had kind of been left on their own or not necessarily brought up to speed with what was happening in the rest of the state. There was not a very good continuity of care if they left a Centurion site and went to GEO or vice versa. So we have gotten them into our electronic medical records, and they now document in the same place for continuity of care. They have identified a leader to work closely with Ms. West and Centurion leadership so that we're all on the same page, and just really improved the continuity among all of the facilities, and the type of treatment is now standardized. Another thing, when you're in a program in the DOC, you are often, that's a full-time job. If you're in PLUS or you're in education, those are the only things that you're kind of doing at a time, and you're focused solely on those. And Ms. West will talk a little bit more about this, but what we did was we moved away from this single focus, only doing substance use treatment, and into what other things in the community might you need to do. You might have to also have a job while you're in recovery. You might also need to get your GED while you're in recovery. So some of these things that once you're released, you are going to have to balance. We wanted to move into that space. Lastly, we worked really closely with classification division, and we are now able to transfer patients for treatment needs. So the same way that if we have a patient who needs higher acuity mental health treatment or needs an infirmary level care for physical health, we historically were not moving participants in this program based on clinical need. And we have since worked with classifications. And now if we identify someone who is not able to get the services that they need at one facility, classifications and us can work together and get them moved. So that's kind of how we did the first bullet point. And Ms. West is going to talk a little bit more about the second.
All right. Thank you, Dr. Dwenger. Good afternoon, members of the commission. So now I'd like to take a little bit of time and explain this diagram that shows the differences between the old program model for addiction recovery services and the new treatment model that we currently have in place. So the previous treatment structure of recovery while incarcerated was based upon this 5 progressions model, where every individual began at progression 1, and then they worked their way through the program to completion at progression 5. The average time for an incarcerated individual to complete RWI with this model was 12 months. The advantage of having this structure was that it provided a lot of treatment to the population with substance use needs, but the disadvantages that we saw was that there was very little ability for individualized treatment with this model, and every person was getting the same resources and same recovery activities. So for example, if we had somebody who was active in their recovery for 5 years and wanted to gain skills and resources to prepare for their release to the community, they were getting the same treatment that an individual who was still actively using substances every day while incarcerated, was experiencing intoxication or overdose events, and still had 20 years left to serve. So those individuals clearly have very different needs, and we wanted to find a way to provide individualized tools and skills that would increase the chances of success for our population. So looking now at the bottom of that diagram, it's showing the current structure that we moved into for RWI, and it's based upon these 3 levels of care. Every patient is now assessed when there's a referral to addiction recovery services, and the recommendation is made for the best level of care clinically for that patient. So on the left, we've got the residential level of care, which is abbreviated as RES, and that's the highest level of care that we offer to our patient population. This is for the patients who may need stabilized, they have maybe regular active use, or possibly they've never had treatment before and they just don't know where to start. These patients are required to live in the recovery-oriented community, which is set up like a living environment completely focused on their treatment and recovery. During that time, they're not permitted to have a job while they're in res or participate in other programs because we want them completely focused on their treatment. Patients in this level of care can make up about 10 to 15% of our population of patients in treatment, and we intend that to take 30 days. So then moving to the center, we've got the intensive outpatient level of care, and that's the next continuum of treatment, and that's abbreviated as IOP. This is for the patients who have either completed that residential level of care or they initially were recommended to begin their treatment at that level. Patients in IOP are not required to live in the recovery-oriented community, and we actually encourage them at this point to maintain a job or participate in other programs while they're in their treatment. This is to help the patients learn to balance work life or other responsibilities in treatment at the same time. Patients in this level of care make up about 20 to 25% of our population in treatment, and we intend this to take approximately 90 days. And then over on the right side, we've got the outpatient level of care, and that's the lowest level of treatment in the continuum, and that's abbreviated as OP. This is for patients who have either completed an intensive outpatient level of care or they were initially recommended to begin their treatment there because of their specific needs. Patients in OP are not required to live in the recovery-oriented community, and we encourage them as well to maintain a job and or other programs while they are in their treatment. Patients in outpatient are focused on building and maintaining their recovery and release plan, and we're helping to maintain long-term recovery for these individuals. Patients in this level of care make up about 60 to 70% of our patient population, and we intend this level of care to take approximately 90 days. This treatment model, we feel, reflects what a community-based treatment model looks like, where there is a lot of focus on learning to balance all the responsibilities, such as maintaining a job, a household, family, children, friends, activities, etc., all while still focusing on maintaining their recovery. So now, Damien, I would like to ask you a few questions as it regards to your experience with RWI. And what I'd like you to share is, what do you feel like was the biggest hurdle to going home as it related to your addiction history?
I think the biggest hurdle, my biggest hurdle always has been myself in life. For some reason, I always seem to be in my own way. That was my biggest hurdle. I was afraid to see how I was going to respond out here. And there, you can practice good character traits on a daily basis. You can see the results of them. But when game time starts, that's when they open that gate. And when you come home, because there's different situations and different temptations out here. And that is the time when you're going to see if whatever you have done has truly paid off. So the main obstacle usually in my life has always been myself.
Okay, thank you for sharing that. And would you mind sharing what you learned in treatment that helped you with that transition going home?
I learned in RWI treatment, I learned several things, but there's a few main things that I clung on to and that I saw results from quickly. I learned that if I maintain a principle long enough, if I practice it long enough, and it becomes habitual. The old habit that I had soon goes away after I've replaced it with a new, better habit. And once I realized that, it kind of it empowered me. I no longer saw myself as a person that was addicted to anything. I did it to myself. I put myself in that prison. I can take myself out of it. And these are things in anything. That could be anger, that could be lust, that could be anything. It just doesn't have to be drugs. So that empowered me. That was the main thing that I clung on to. The power of choice and the power of directing your thoughts and living purposefully.
Oh, fantastic. I appreciate you sharing that with us. So now the final slide that I would like to share is where we're moving with RWI. And the future of recovery while incarcerated is so very exciting to me with all the projects that we want to include for our patient population moving forward. The first thing I want to talk about is including peers in RWI, and that's a big priority for our treatment to allow those individuals with lived experience in substance use to connect and support each other. DOC collaborated with ICATA and Mental Health of America, Indiana to conduct a pilot program at Putnamville and Pendleton correctional facilities. And what we did was provided training to incarcerated individuals. We were able to get 39 incarcerated males to pass the exam, and they actually obtained their certified peer recovery coach credential while they were still incarcerated, which was just phenomenal. And they can use that out in the community as paid employment. So what we would like to do is expand that training to as many facilities as possible and be able to have these certified peer recovery coaches working with as many of our patients as possible. Just something that's really exciting. And I know the feedback that we got from both the population and the staff has been very positive on that. The second thing I want to talk about is expansion of medication-assisted treatment. And that's another priority for us moving forward with services. We want to be able to receive individuals from the community or jail setting who are on MAT and continue in that same level of care that's been successful for them. Being able to expand that to a larger population during their incarceration will provide another tool for them to remain free from substance use during their time incarcerated. The intent is to decrease medical costs and interventions, increase safety for both the staff and the incarcerated population, and increase the chance of their long-term recovery. We also want to expand the number of individuals that are released back to the community on MAT during that vulnerable time in an incarcerated individual's life to hopefully decrease the recidivism rates. The next focus that we have is to evaluate the DUCR, which is our current assessment tool that we use to identify clinical needs for our incarcerated population. We want to ensure that we're using the most current and effective assessment tool for the addiction recovery staff when they're making their clinical recommendations for treatment. The independent study material that has been used for DOC is outdated, and we've begun to identify new evidence-based material to provide to them. Foundations is our independent study treatment that we offer, and this is for patients who are not eligible for a group treatment setting. And the intent with that is to be able to provide education, resources, and skills to this population through completing material that they can access regardless of their circumstances and work on it at their own pace. And then the final project that I want to discuss today is expansion of treatment options to that population of individuals that are not eligible for the group setting. A large portion of the incarcerated population are housed in locations that currently do not have a safe way to provide groups for RWI, such as some of the mental health units and the restrictive housing units. The individuals who are waiting to get enrolled in treatment also do not get to participate in groups, and we would like to be able to provide additional resources to them during that waiting period so they just don't feel stagnant. We've identified Breaking Free, which is a tablet-based interactive treatment resource that the incarcerated population could access 24/7, and the material is tailored to their personal needs. The technology also could follow them for up to 1 year after they're released from incarceration. Additional workbook resources have been identified for that population to learn the skills necessary if they are not able to attend group treatment. So that concludes what we have for slides, and I think we would like to open up the conversation to comments or questions that anyone may have.
Are there any questions from the commission members? Well, I would just want to say, thank you to Dr. Dwenger, Ms. West. We've been working on this for a very long time. I want to thank Dr. Doss and Commissioner Carter for their support of this program. We've seen this evolve over time, and I just couldn't be happier with the progress that your team has made.
Thank you.
Hey, Doug.
Yes, Commissioner Carter.
Yeah. Hey, I want to make a couple comments. I'm not real sophisticated. I'm kind of like Damien, but the backlog about almost a year ago, Dr. Dwenger and Dr. Dawson and I were talking about the backlog, and we had one heck of a hole to fill, and we had a small shovel at the time, and they worked, and I think bringing on Ms. West was a huge asset at the time. So we for them to get from where we were at to where we're at now, that's an incredible feat, and I'm real proud of these ladies, especially with the start with the leadership of Dr. Dawson and Dr. Dwenger and Ms. West. They've done one heck of a job, so very proud.
Yeah, thank you. And I know a lot of this started with Dr. Doss and I. We traveled with the National Governors Association to some meetings on this topic. And, at that point, we were talking about just the baby steps that we could make. And with the partnership with the Division of Mental Health and Addiction and our Indiana Sheriff's Association, we have seen just a massive movement in the last 2 years, and especially the last year, in not just substance use treatment, but also mental health treatment in a lot of our correctional facilities. So thank you for all the work that you've done. Well, let's move on to our next agenda item. Our next presenter is Dr. Chris Drapo from the Family and Social Services Administration. He is the Director of Prevention, Suicide Prevention, and Crisis Response at the Division of Mental Health and Addiction, and he's going to present on the federally mandated 988 Crisis Helpline. In 2020, Congress took the significant step forward with the enactment of the National Suicide Hotline Designation Act. This designates 988 as the 3-digit phone number for Americans in crisis to connect with suicide prevention and mental health crisis resources. Here in Indiana, 988 will not only be a call center, but over the next few years, we aim to build a system that responds and connects Hoosiers experiencing mental health crisis with the appropriate services. And this goes a long way to begin to connect the work that our Justice Reinvestment Advisory Council, the legislature are all doing to revamp the way that we deal with mental health in the, and not just in the public, but also within the justice system as well. So lots more on this topic as we move forward, but there's a lot of work to be done over the next few years. And I appreciate Dr. Drapo taking time to share the 988 plan. Chris?
All right, thank you, Doug. I'm gonna go ahead and share my screen 1 second. Okay, so again, thank you, Doug and commission members. This is a topic I'm really excited about presenting on and interested to know your questions, thoughts as you learn more about this. This is big, it's bold, and it has potential to address a lot of the issues that we care most about. And as Doug did mention, we know in the fall of 2020, former President Trump signed the National Suicide Hotline Designation Act of 2020 into law. And I was accompanied by the FCC mandating that by July 16th of 2022, all cell phone carriers would be directed to divert the 988 calls or to activate 988. So these calls would go to the National Suicide Prevention Lifeline. So one thing I want to dispel, I know there's a lot of confusion out there. What exactly is 988? It's not really new. It's a new number, but the National Suicide Prevention Lifeline has existed since 2005. but they currently have a 10-digit number, 1-800-273-8255, and this will be condensed to this 988 number. And then there will be marketing efforts to make it clear that this isn't just for preventing suicide, but as Doug mentioned, it's also mental health crisis related. And substance use crises have also been brought up as a potential focus in just talking about behavioral crisis care in general. So just to give you a heads up there. And I want to point out some things from this National Designation Act in case you haven't seen this yet. And so I bolded some things in red because I know it's a lot of text. But it goes beyond just the 988 number or the crisis line. This provides an opportunity for states to invest in a crisis system that goes beyond just the 988 call centers. And so this could be mobile crisis response teams, crisis facilities, and states have the opportunity, if they wish, to enact a 988 user fee on phone bills that could provide a permanent funding source for the entire crisis system moving forward. And there are several states that have done this so far, and many that are considering it. And so I just want to bring this to your attention, that this goes well beyond just a call center. It's the whole system. In Indiana, last year, during last session, House Bill 1468 was passed, which set up the 988 trust fund for the state of Indiana should they ever divert funds for this crisis system in the future. As you can see here, it also covers more than just a crisis hotline. It covers mobile crisis response teams and also crisis receiving and stabilization centers. But essentially, this is where we're headed. The most simple way we can put it is ensuring that every Indiana resident has someone to call, someone to respond to them, and a place to go, and making sure that we build a system that can serve anyone, anytime, anywhere. So very similar to what Dr. Dwenger shared earlier about making sure we have the right care at the right time for the right person. This is the same thing for the whole state of Indiana for crisis care. And you've probably seen this slide before if you've been on any webinars that have talked about 988. This slide seems to make an appearance. And if you're not familiar, this is from the southern area of Arizona. This is data from 2019. So Arizona splits their crisis services into 3 different regions. This is the southernmost region. And so what they found from these data is that the majority of people who reach out for crisis concerns to their hotline, their crisis line, they found that 80% of them are stabilized at that level and don't need additional care. But for those who do, 70% of them are stabilized at the mobile crisis level, and those who need another level of care go into the crisis receiving facilities. You see the majority are stabilized there, and many remain stable in the community thereafter. And I think one of the outcomes that we care a lot about, those of us attending this meeting, is diverting people in crisis away from costly and restrictive interventions such as jails, prisons, hospitals, and inpatient units. And they found that this system in Pima County and other counties in Arizona has done just that, and something that we can hope to replicate in Indiana as we move forward. And also ensuring, I don't know how many conversations you've had with law enforcement and first responders, but I know personally talking with them, they mentioned that a large number of their calls, a lot of the hours that they spend on the job is responding to mental health crises. And Arizona has seen, and other parts of the country have seen, that when you create a system like this, you free law enforcement up to focus more on public safety and provide more competent and efficient care to people in crisis. And so the plan is that eventually we stand up our 988 call centers in Indiana to serve as the glue or connective tissue of the crisis system. You could call them air traffic control centers. Others have said care traffic control centers. Essentially what they're doing is ensuring that those who reach out for help do not fall through the cracks and are connected to the care that they need at the right time. And so these are some of the services, if you look here at the bottom of the slide, that could be offered. Not just dispatching mobile crisis teams, but also ensuring that they have bed registry information for those crisis receiving facilities so they know what's available and where to direct people to if a mobile crisis team will transport. Also providing the opportunity to schedule 24/7 outpatient appointments, because we know that's an issue throughout the state, is getting people into care after a crisis. And of course, ensuring that we are holding ourselves accountable, because this system is being built for the public, and making sure that we have publicly available data so the public knows exactly how we're doing. It also puts the impetus on us to ensure that we're continually getting better and better for them. So we sent a survey out last summer to residents throughout the state, just trying to get a lived experience perspective on what do you understand about 988? What would it take for you to trust reaching out to it in the future? We had 820 respondents. The majority of them came from Marion and Allen counties, but I noticed that a lot of the qualitative feedback we got matches up really well with the definition of person-centered care. And that was one thing I noticed in the feedback. There's a lot of people in Indiana, they want more person-centered and trauma-informed care when it comes to figuring out how to get support in a crisis. And so dignity and respect, this came up more than once, where people want to feel like those they're reaching out to care about them and what they're going through. But also they don't want to be minimized. And I've heard, I don't know if you have, but I have heard of experiences where people have reached out to crisis lines and they just feel like they're getting somebody who's just reading a script. It's not really listening to what they're saying or isn't responding quickly. And so they feel disappointed, they feel disrespected. So how do we build a system that can give them that connection and concern and care that they're looking for? The next part of this is information sharing. And so making sure, going back to that transparency, are we giving people the information so that they can make informed decisions? Because as you can see here, some people are nervous. If I call this number, is law enforcement going to take me away? Is an ambulance going to show up, meaning that I have to now pay an insurance or have to pay a bill that my insurance may not cover? What does this mean for my loved ones if I reach out for help? So figuring out how we can share this information with people so they know exactly what they're going to get. And then standardizing the system and training so that no matter who responds, they get a consistent response that they can depend and rely on. Again, building trust in the community so that they will use the system, because this is who we're building it for. And if the public can't trust it, then what's the point of investing our time and money into this? In addition to this becomes participation. People want more voice. They want more choice in what happens to them when people respond to their crisis. So it's figuring out how, we know when you're in a crisis, that's a very high level of stress. It's hard to think straight, but how can we stabilize people to a point where they can participate in what happens next? So you can see some of the feedback here. We want greater autonomy. We want to be able to know what are the options and to collaborate with those who are responding to us to decide what works best. Because if you think about it, if we have to involuntarily hospitalize someone, we choose to do that without considering all the evidence in that moment. Are we thinking about the implications on that individual? What if they're working an hourly job, they don't have paid time off? How does that impact their ability to pay the bills? Are we thinking about all these details that we may be missing and maybe contributing to exacerbating their crisis because of how we're responding? So making sure we're collaborating with people ensures that we're thinking about what's best for them and not what we are doing because maybe we're afraid of liability or some other concerns or assumptions we have about people in crisis. Again, just mention collaboration. So people are afraid of reaching out because they're worried about being taken away against their will. And so making sure that people have the chance to be engaged and have a say, and us being respectful of that, I think is a great way to improve trust in this system and ensuring that the outcomes we see are the outcomes we want to see, because we're putting the public first and we're pulling feedback for them to inform what we do. So this is just some feedback from that survey. We don't have all perspectives in Indiana represented, but we hope to do a better job of doing that moving forward so we can truly understand the nuances of what this crisis system must address if we want it to be successful. And this is the vision which is developed from the conversations that have been going on since last year about 988 and the entire crisis continuum. And really, we want to make sure we're building a crisis response system that's quick, that's efficient, that provides competent and nation-leading crisis response services for every Indiana resident. And the more you think about that last part of the vision, every Indiana resident, you realize the magnitude of such an effort. And it's going to take a long time to figure out how we can do that well, because we know the system currently is not accessible to everybody. Even just thinking about foreign languages, deaf and hard of hearing, visually impaired, communities who historically mistrust reaching out for help. We have to figure out how to engage with all these communities and find a system that can give them what they need at the right time. But also making sure, and I want to make sure to make a point of this, that peer support professionals are a significant part of the entire system, because we know, we've heard from people that they want to talk to those who have been through what they've been through. That creates connection and builds trust. It allows people to know they can believe in the system because they see how it's impacted other people's lives for the better. All right, so essentially what I'm arguing for is that we make sure, using systems level thinking, we know that systems produce exactly what we ask them to. So we need to make sure that the goals of this system are focused on the needs of Indiana residents first and foremost, and everything else is an appendage to that. And making sure that whoever oversees this system never forgets that this is for the public and the public alone, so that we're focused on the metrics that allow us to know whether we're doing our job to the best of our ability and whether they're getting what they need. So just pointing out that systems thinking and making sure we're focusing that system on the goals that matter most. We've had a number of core area planning committees that have been meeting to discuss how to prepare for the launch of this 988 number in July of 2022. I do want to clarify, though, we don't have to have the whole system mapped out by July. We just have to be ready to answer 988 calls by July 16th of 2022. And then over time, we'll figure out how to make sure we have the capacity to answer higher rates of 988 texts and chat messages. But mobile crisis and crisis stabilization, we have time to figure that out. And as many of you know, you can't figure all that out in a year or even a few months. It's going to take a lot of time. There's a lot of systems, a lot of partners to engage. So just a FYI on the timeline there. Right now, we're considering the future of these groups. We've figured out a number of these things already through a Vibrant State 988 planning grant, which just ended, that these groups were informing. If you're not familiar with Vibrant, they are the administrator of the National Suicide Prevention Lifeline and also will be administering 988 on behalf of SAMHSA, a federal government agency. So we are trying to figure out those last questions, remaining questions we need to address for launching 988. We also applied for a SAMHSA 988 grant, which will help our planning even further. We should hear back on funding decisions in the next month or so. And I just want to include this from Dr. Margie Balfour's group in Pima County. These are some lessons that they've learned so far. Having one of the top crisis systems, I think we could argue in the country. But they found that it's really important that we have stakeholders at the table who are not looking for reasons to say no, but reasons to say yes and figure things out together, that we're focused on quality improvement and also ensuring that this is a no wrong door system that can serve anyone, anytime, anywhere. That's pivotal. There are parts of the country where they've attempted to do this and they said, yeah, we'll take you, but you're a little too violent. You're a little too psychotic. We can't handle that. Well, a number of us went to Pima County, Arizona in November, and they shared in their crisis response center, they truly embody this no wrong door approach. So there are parts of the country that have figured out how to do it. And I truly believe that Indiana, it's just a matter of when for us. If we all come together and believe in the vision of this, we'll figure out how to do it and do it well. So Doug, commission members, I'm going to end here. I'm happy to answer any questions or take any feedback.
Well, thank you. Questions for Dr. Drapo?
I have a question real quick. I know when I was going through my madness, my family was wishing that they could get some sort of support. Is this also for family members, or is there going to be a branch for family members who have loved ones who are struggling?
That's an excellent question. So we want to build this so it's accessible for as many Indiana residents as possible. And, we found in that survey I mentioned that the majority of people who responded say they actually have reached out to 911 and the National Suicide Prevention Lifeline on behalf of a loved one. So we know that we have to be prepared for that because a lot of people do reach out for others who are in crisis. So we do have a grant award through the National Association of State Mental Health Program Directors. And that's focusing our attention on crisis response and diversion for youth and families, primarily, and of course, adults secondary. So to answer, the short answer is yes. We want to make sure that we can do that and provide that level of support.
Great question. Any further? Well, thank you, Dr. Drapo, for joining us and providing the information. Lots of work to do. So. Thank you. Next up, we have Devin McDonald, Director of the Criminal Justice Institute, to share a update from his agency on the local coordinating councils.
Thanks, Doug. Yeah, just a few quick updates, and then I will eventually share my screen. We made some significant improvements to our website, so I'd like to kind of show those so we can see what the LCCs will be seeing and working with as we move forward. So a couple of the big points. One, we currently have 3 LCCs that are continuing their drug-free communities grant. We anticipate one of those counties, Scott County, to continue with their grant because they're the ones that have really been working on the coalition network that's been developed over the past couple years, actually. So looking forward for that to continue moving forward and providing more resources for the LCCs around the state. CJI, our Behavioral Health Division, under Michael Ross, is putting together our 2021 annual report for all the work the LCCs did. We're finalizing that. It should be available here in about a month or so. About the same time, we'll be publishing our updated policies and procedures manual for the LCCs. The current manual is the first time in, I couldn't tell you how long, probably a decade or better, that an updated policies and procedures manual or a good policies and procedures manual has really been made available to the LCCs. That kind of uniforms the process as far as the comprehensive community plans, the reports, and everything else that goes along. Through the past year, we have 87 active LCCs. Of those LCCs, all of them submitted and had their comprehensive community plans approved, which is good. That's another highlight that's been happening over the past couple of years, which is a little different than what's happened beforehand. So good work being done there with Michael and his folks. As part of the website and the policies and procedures, we're also working on updating our online training materials to provide a good resource for all the LCCs to go to if they have questions over the comprehensive community plans or policies or other issues for that fact. They'll be able to go to this online resource and look up those trainings themselves. And then kind of the last 2 points here, we've really been working over the past year to develop a LCC advisory group. We've got that group together. It's comprised of a couple individuals from CJI, Michael, and a few of his the program managers within the behavioral health division, as well as 16 members from the LCCs. They had their first meeting a little while ago. Their next one's scheduled for later this month. So really looking forward to that group getting together and putting some good things out for the LCCs, networking possibly, and being able to provide LCC to LCC or peer type coaching across the board. So really looking forward to that. And then the last thing, as we revamp the website, we're also looking to improve our data dashboard so we'll be able to provide even more data through these updates. So if I can make this work, I'm going to try to share my screen real quick, kind of like Commissioner Carter and everybody else. I'm not too tech savvy. So try to share my screen real quick, just run through a few slides so I can show some pretty significant website updates that Michael has been working on along with Ben, our communications director. So bear with me 1 second here. All right, can you guys see that?
Not yet.
Not yet. Okay. Let's see.
There we go.
All right. I have no idea what you're actually looking at right now. So hopefully it's the actual slide and not the actual PowerPoint program. Obviously that's me. That's what we're reporting on, the LCCs. So as you see, their website update, like I said, it's just hopefully a further resource for the LCCs to update, be able to update their comprehensive community plans, streamline that process, as well as provide some good data to the commission and or others throughout the state, and provide a good source of reference materials for the LCCs. Here's kind of one of the opening pages to the behavioral health division. You can see there in the middle of the page, the policies and procedures manual. That's where it'll be located. The LCCs will be able to pull it up and download it. Provides kind of the bare bones aspects of what is to be expected from the comprehensive community plans, or what we expect the LCCs to produce and provide. Again, it'll go over that, the plans are due in April of every year. We review those and then issue approval letters after that. Here on this page, we talk about the SMART goals that we have for the LCCs, things that we want to do. Again, these are just more resources for them, some education and materials for them as they develop their comprehensive community plans and the goals that they put together. One of the pieces of feedback that we did get from the LCCs throughout the past couple of years is that they really wanted these more online materials so they could be a little more self-involved without always having to come to us to ask the question or send an email or something like that. We'll have these resources available for them to download, take a look at, review, hopefully produce better information as we move down the road. On this page here is where we'll have all the reporting requirements. The LCCs are required by statute to upload their meeting minutes, send us their meeting minutes. They'll be able to upload those here. We'll be making those available for people to review should they want to, or take a look at what's happening around the state. Here's that online kind of resource database that I mentioned previously. So they'll be able to look at past surveys, materials, the grant agreements if they need those. We'll have some templates on there for them to download as well. And then finally on this page, this is a little bit different. This is already available on the website, or was previously, but you could click on the county. It would pull up the name of the LCC, who the director is for that LCC, and some contact information. So we'll continue that. We're going to update that even more as we move along, especially with these website updates. And then this is where we'll post our quarterly newsletter for the LCC updates as well. So with that, that's all I have for that. I know it was pretty quick, but just a quick sharing of some website updates. Hopefully it'll make lives a lot easier for those at the LCC level.
No, thank you. Any questions for Director McDonald? All right. Well, as we move to the end of our meeting, I want to thank everyone again for the presentations and for your time. Before we close, I'd like to take a moment to recognize a retiring member of our commission. Representative Cindy Ziemke couldn't join us this afternoon, but I think it's important we recognize her contribution to our state. She has long been a champion for individuals with substance use disorders. And for her, this fight is deeply personal. Many of you may remember that at our second ever commission meeting in 2017, Representative Ziemke invited her sons, Sean and Connor, to share their past struggles with addiction and their journey to recovery. And prior to introducing her sons, I remember Representative Ziemke saying how crucial it is for the commission to hear Hoosiers who contribute to and lead a successful path to recovery. And so from that point on, we have invited Hoosiers to share their personal accounts of recovery, to put a face to the disease, and to prove that recovery is possible. So Representative Ziemke has made it her personal mission to bring awareness to addiction, even at a time when that wasn't normal to talk about. So during her time in the legislature, she's authored and sponsored bills limiting opioid prescriptions to first-time patients and children. She's helped scale up Indiana's addiction treatment infrastructure and expanding the availability of naloxone, a tool that even helped save one of her sons' lives. I'm personally going to miss her advice and counsel, but I'll take comfort in knowing that she has promised to still answer my calls and have a plate of fried chicken ready at a restaurant anytime I'm passing through town. So Representative Ziemke, on behalf of all of us, thank you for your service to this commission and to all Hoosiers with mental health and substance use disorders. With that, I appreciate everyone's time and attention today. Our next meeting is Thursday, May 5th in 10 o'clock. It'll be at the Indiana State Library in the History Reference Room, and more details will be shared closer to the meeting. So thank you for joining us this afternoon. We stand adjourned.
Thank you.